Good evening to all of you. Now we have come to the last segments of the annual academic session of Sri Lankan College of Internal Medicine. So this is a plenary, 8th plenary. So now we have a presenter from the USA, Dr. Lillian of Lynn. She is a division director of endocrinology and a professor of medicine with tenure and the University of Mississippi Medical Center. Uh, she has many publications, and she is going to tell us about the navigating thyroid functions through the case studies. So over to you for your talk.
Hello, my name is Dr. Lillian Lien, and I have the honor of being the division chief for the Division of Endocrinology, Metabolism, and Diabetes and professor of medicine at the University of Mississippi Medical Center here in Jackson, Mississippi in the United States. And I would like to thank very much the American College of Physicians as well as the Sri Lanka College of Internal Medicine, especially for your invitation to participate in your meeting. I'm really honored by this opportunity. And for the sake of time, let's go ahead and get started. And what I'd like to do first is discuss that I do have disclosures. I do pretty low-level consulting with a number of companies in the United States that deal with diabetes, but I will say that's actually completely irrelevant to this presentation on thyroid disease. Also, I tried to base the talk on 100% on guidelines to avoid bias as much as possible. And so let's go ahead and get started. The topics that I picked, thyroid disease is an extremely broad topic, but the topics that I wanted to highlight in our brief time are ones that I think would be especially useful for the internal medicine physician. And so let's start with the challenge of hyperthyroidism. I was really excited about the idea of doing a case-based presentation. And so when I thought about cases, it turns out that some of the best are actually the vignettes that come from the MKSAP, the Medical Knowledge Self-Assessment Program that is put out by the ACP for board review purposes for internists. And so several of the cases will come from this format. This, in fact, is a sample question from the ACP MKSAP. And so the case is presented as a 28-year-old lady who has worsening eye symptoms, so Graves' ophthalmopathy. She's known to have Graves' disease, so that's not a new diagnosis, and she was appropriately placed on methimazole therapy. Unfortunately, as is often quite common, these medications have side effects, and therefore she became neutropenic and absolutely had to come off of the methimazole. However, in that process of that, her orbitopathy has worsened and actually to the point of discomfort and double vision. On the physical exam, as expected, there's demonstrated a thyroid gland with that is clearly enlarged, quite smooth, consistent with the Graves presentation. And her eyes really do appear to be in trouble. She has bilateral chemosis, erythema, and proptosis. Worse than that, the MRI, the orbital MRI demonstrates that she has an increased size of her extraocular muscles. In other words, they are hypertrophied. This can be very remarkable with Graves' orbitopathy. And her labs are entirely consistent with the expected hyperthyroidism, with a TSH that's suppressed and elevated free T4 and T3 levels. Not surprisingly, with the Graves' disease diagnosis, her thyroid stimulating immunoglobulin is grossly elevated. So the MKSAP question presents what the next most appropriate therapy would be and gives the option of iodine, switching from the methimazole to propylthiouracil, PTU, proceeding with radioactive iodine therapy, or surgery, thyroidectomy. And the appropriate answer for the MKSAP question is, in fact, surgery, thyroidectomy. And that's because oral iodine solution would not be of much help and might actually cause changes in her thyroid hormone profile potentially worsening the hyperthyroidism and also making the eye disease worse. Unfortunately, switching from methimazole to PTU is discussed by a lot of folks as an option, but not generally accepted by experts in thyroid disease to be safe because of the issue of cross-reactivity. In other words, if there's neutropenia on the methimazole, there's a great fear that there will be a similar and severe problem with the PTU. Radioactive iodine therapy might be an option in a setting with less severe ophthalmopathy or certainly with no eye disease. But in this option, it's completely contraindicated, therefore leaving thyroidectomy as not only a definitive option, but an opportunity to quickly resolve the issue so that thyroid hormone levels can be stabilized. And that is really the only way to resolve the eye disease. So with that case scenario and question and answer set, we actually have gone through a number of treatment options for hyperthyroidism, but I'd like to back out and put it in the context of the differential diagnosis for hyperthyroidism. Since again, this is something that the internist sees quite commonly, we all know that there are so many different causes, and how do we define that differential diagnosis in a categorical way? And one way to do that is using the option of the diagnostic tool of the radioactive iodine uptake. And this is really the textbook answer for how to differentiate between different types of causes of hyperthyroidism. The big split is between the high uptake states and the low uptake states, with the high uptake states reflecting an underlying thyroid hormone synthesis, whereas the low uptake states actually represent inflammatory processes as an underlying cause of the hyperthyroidism. So the most common high uptake states would in fact be Graves' disease, which of course is a key characteristic of that can be Graves' ophthalmopathy. Toxic multinodular goiter is also a high uptake state, and those would be the most common. The other items listed in the slide are luckily fairly unusual, and I personally have not seen a TSH pituitary adenoma, although it is always on our board options as part of the differential. With regard to low uptake states, this is most commonly thyroiditis, and that can be any of the different forms of thyroiditis, whether that's subacute or de Quervain's thyroiditis, silent or even postpartum thyroiditis. Another key option in the low uptake side of the differential is exogenous thyroid hormone, and that can be in the form of someone actually taking thyroid hormone, or as we've seen in some cases, a supplement that the patient may not even know contains thyroid hormone. And that leads to, of course, iatrogenic hyperthyroidism, also known as thyrotoxicosis factitia. And struma ovariae is a very rare presentation that would also be a low uptake state and cause of hyperthyroidism. So having run through that broad differential, it helps us to understand our choice of therapy to some degree. In terms of medical therapy, I'd like to start with the medical category first, and we'll talk about the most common typical choices of medical therapy. And then later we'll get back to some of the more unusual options for the very severe cases of hyperthyroidism or even emergent thyroid storm management. So let's start with the more typical medical choices, and then we will also move on to the other definitive options of radioactive iodine and surgery. So medical therapy always starts with beta blockade unless there is some clear contraindication. The use of the beta blocker is essential to help with tachycardia, may even symptomatically improve how the patient feels. There is a technical reality that propranolol can be used as the specific beta blocker because of its characteristics with the ability to block T4 to T3. T4 to the active T3 hormone conversion can be blocked, but only by very high dose propranolol. So often this is really a more academic point, and any beta blocker will at least manage the tachycardia, whether or not we worry specifically about conversion blocking. Now, the other typical therapies of typical medical therapies now have to be considered in terms of that differential diagnosis. If we are talking, and we most often are, of a high uptake state, as we said, Graves or toxic multinodular goiter, then we need to block synthesis. And this can be done with thionamide therapy, which in the United States is generally propylthiouracil PTU or methimazole, with methimazole generally preferred from a safety standpoint, although they both can cause agranulocytosis, thrombocytopenia, and vasculitis. So these are not necessarily the safest drugs to begin with, but we use them when we have to. PTU, in 2009, the US FDA actually put a black box warning for fulminant hepatic failure, and that has really pushed PTU more into a background role. PTU does offer the opportunity again to block T4 to active T3 hormone conversion, and for some that is a reason to use PTU in very severe hyperthyroidism or STORM. But again, because of the liver issues, methimazole has been generally moved to as a preferential starting point. One caveat is that pregnant patients in the first trimester do have the risk of adverse effects from the use of methimazole, and so PTU is recommended specifically in the first trimester of pregnancy, with the option to switch to methimazole once the second trimester comes along. Now, in the situation we talked about of low uptake states that are inflammatory, and that's the driving force behind the hyperthyroidism, in that case, steroid therapy is extremely helpful to treat the inflammation. And if it's pure thyroiditis, then in that case, actually steroids will be the most effective, because either PTU or methimazole will not make much of a difference in pure inflammation if there's not an underlying synthetic problem. So again, we're talking about the typical types of thyroiditis, not Graves' disease and not toxic multinodular goiter. So in pure thyroiditis, steroids are the best option. Besides beta blockers, PTU or methimazole, and steroids, there are other options for medical management, which are more often moved to only in cases of severe hyperthyroidism or the emergency of thyroid storm. We'll get to those later. What I'd like to do is say that we've discussed the typical medical therapy options, and then talk about how we would move to definitive therapy in terms of ending the hyperthyroid situation for the patient. And in the United States, and I do understand that this is not accepted as the go-to around the world, but in the United States, there is no question that radioactive iodine therapy has been thought to be the most definitive treatment, because it allows you to eventually come up, once the medications have worked and the hyperthyroidism has been stabilized, you come off the medications prior to radioactive iodine, and the radioactive iodine has a delayed effect in which it leads to the development of hypothyroidism, although this does take time, often as long as 3 to even 6 months, but that is definitive. In most cases, one treatment of radioactive iodine leads to the several-month development of hypothyroidism, and the patient can simply take Synthroid for the hypothyroidism, and in general never has to deal with hyperthyroidism again. There are rare cases when radioactive iodine the first time has failed and has required a second treatment, but that's very rare, and in those instances, I've never seen a failure of the second treatment. So radioactive iodine therapy is definitive. However, there are caveats. First of all, for obvious reasons, it should never be used in a pregnant patient. As stated before, a patient with severe Graves' ophthalmopathy, the radioiodine could actually acutely make this worse. And so this is generally avoided unless the ophthalmopathy is quite mild. And even then, that might be in consultation with the ophthalmologist and possibly with pre-treatment with steroids. So in general, really extreme, especially eye disease, should completely not, a patient with that situation should avoid radioactive iodine therapy. Fortunately, the therapy goes quite smoothly, but we do have to realize that there are post-treatment radiation precautions for the patient to avoid young children or pregnant women. And rarely there can be salivary gland uptake or radiation thyroiditis as post-treatment problems. unfortunately, in my experience, especially again here in the US where this is used so commonly, that is quite rare, and it is thought to be an effective and definitive option. Now, as we said, besides medical therapy or radioactive iodine ablation, surgery is obviously definitive. However, it of course requires pre-op preparation. So a grossly hyperthyroid or severely hyperthyroid patient would still need medications first to bring down the hormones and essentially calm the system down in such a way that it would be safe to proceed with surgery. Surgery obviously quickly lowers thyroid hormone levels, and the circumstances where you would move to actually perform surgery for hyperthyroidism are limited, but we've already discussed one of them with severe Graves' orbitopathy. It may be an efficient way of taking care of the problem. Take out the thyroid, and after the thyroidectomy, the patient is placed on a weight-based dose of Synthroid. The thyroid hormone levels are stabilized and the eyes can be managed. In addition to that, when we don't have the option of methimazole or PTU, as said, because of side effects such as agranulocytosis or vasculitis, then sometimes it is necessary to move to surgery. Amiodarone-induced hyperthyroidism is an area that I have often seen end up leading to surgery because the amiodarone is often a necessary antiarrhythmic for the patient, and the hyperthyroidism is considered the side effect of the amiodarone, and this can sometimes be most acutely cleared by performing thyroidectomy, allowing the patient to become hypothyroid, treating that with Synthroid appropriately, and therefore resolving the thyroid issues and continuing the amiodarone. So that gives you some idea of why we might move to what would otherwise appear to be the extreme choice of thyroidectomy. So having been through the whole broad treatment options, let's talk about the more unusual choices of medical therapy in the very severely ill hyperthyroid patient, or in the case of an emergency such as storm, where it's not merely that our thyroid hormone levels are elevated and usually excessively elevated, but the patient is ill with fever, tachycardia, arrhythmia, possibly even an intensive care unit situation. In that case, we're going to throw on all of the previously discussed medical therapies. Beta blockade to begin with, antithyroid therapy, because usually in a patient that sick, we don't know the differential diagnosis, so we have to assume that the high uptake states are a possibility. And so that would mean starting with the beta blocker as well as PTU or methimazole. And steroids are often added on as well, because in acute cases, the anti-inflammatory properties are helpful. And if it is a thyroiditis, then as we said earlier, the steroids are essential. So once all those are on, if the patient, and I have seen this case several times, is still decompensating, then we've got to move forward with more aggressive therapies, including iodine. SSKI is an abbreviation for saturated potassium iodide, saturated solution of potassium iodide. And that can be used to try to block the gland down if all the other medical therapies have not been effective. It should be given 1 hour, though, after the PTU or methimazole to avoid the iodine being used as a substrate. Lithium is in the literature quite a bit. I have personally not used lithium as a management option for hyperthyroidism, but it is in the literature. I have used cholestyramine, but this truly is a last-ditch effort to literally just bind thyroid hormone, some degree of desperation in trying to help the crashing patient. And if all of these therapies fail, obviously this is a patient too unstable for surgery, and so we would have to move to the extreme case of plasmapheresis. And I've only seen that done a handful of times, but it can potentially be life-saving. Okay, so let's switch now to the other completely opposite topic of hypothyroidism. And in this case, obviously, we're dealing with insufficient thyroid hormone. And so the purpose, of course, is to restore thyroid hormone levels, but we want to do so in a way that doesn't overtreat and end up with cardiac arrhythmia. We also would like to do with the thyroid hormone restoration so that the rest of the clinical deterioration of other organ systems don't occur, as chronic hypothyroidism can have a lot of negative effects, especially on the heart. But how aggressive to replete the thyroid hormone is really less dependent on the labs. Of course, the TSH matters, but more really on patient factors. So let's first talk about usual replacement. So the American Thyroid Association has clinical practice guidelines that give a weight-based option for thyroid hormone replacement. The ATA recommends T4 thyroxine, synthetic L-thyroxine, specifically known as levothyroxine. In the United States, a common brand name, although this is only one of the brands, is Synthroid. However, levothyroxine is the generic form, and that is recommended over other thyroid hormone preparations because of its reliability. The weight-based calculation estimates approximately 1.6 micrograms per kilo as a daily dose, and that generally is a good estimate, but it's important to emphasize we would start with that dose in a young, healthy patient without other comorbidities. We would have to be more cautious in the older patient or the cardiac patient. And specifically, this brings us to another MKSAP question case regarding an 80-year-old patient who is being treated for depression, but also reports weakness, fatigue, and weight gain. Unfortunately, her medical history is complicated, including angina and congestive heart failure. She has symptoms that are consistent with hypothyroidism, including delayed reflexes and mild bradycardia. As expected, her TSH is quite elevated at 95 and her free T4 is 0.1. But although these labs look rather alarming, this is not an emergency because she is talking to you and telling you about her symptoms and able to converse comfortably. So, given the scenario, the MKSAP question offers you several therapeutic options. And as can be expected, the most cautious option is really the answer that they're looking for. And that is levothyroxine replacement as discussed, but not at weight-based therapy, at only 25 micrograms daily. And this is because replacement must be done very cautiously in either the elderly or the cardiac, or in this case, both patient. A real-life case that gives an example of this, we had a patient recently in the hospital here who really had a complicated situation with thyromegaly as well as severe aortic stenosis, underwent an unusual situation with a complicated dual procedure, aortic valve replacement and total thyroidectomy. Post-operatively, the patient surprisingly actually had labs that appeared somewhat hyperthyroid, and so the critical care team had asked us about replacement, and I said that in the setting of what appeared to be resolving hyperthyroidism, we could not give Synthroid right away, could not give levothyroxine immediately. By post-op day 4, however, as expected, since there had been a total thyroidectomy, thyroid levels were falling and the free T4 was now borderline low, and we knew it was time to initiate replacement. But we have a critically ill patient who just had multiple surgeries and was hemodynamically still compromised in the cardiac ICU. So the decision was to give IV levothyroxine at a very cautious dose of 12.5 micrograms, which is equivalent to the PO levothyroxine dose of 25 as recommended by the guidelines. Specifically, the idea is with the older patients, the American Thyroid Association recommends 50 micrograms daily as the starting dose, and with the cardiac patient, a lower dose of even 12.5 or 25. I'd like to briefly go through the situation of hypothyroid emergencies, myxedema coma, which fortunately is extremely rare. So we see hypothyroidism, but fortunately we do not generally see extreme hypothyroidism to the case of coma. However, when it occurs, it's extremely dangerous with a high mortality rate. And the presentation is usually quite obvious as there is somnolence or stupor, or often even just a coma presentation. The patient is bradycardic, severely hypothermic with a body temperature less than 35 degrees Celsius. Often hypoventilation will require intubation and GI symptoms, sometimes including ileus. The case here from the MKSAP series is an 84-year-old lady who presents from a nursing home completely altered and able to give you a history, but she is bradycardic, hypothermic, Her skin and hair have changes consistent with hypothyroidism, and she's even hypoglycemic. And the question asks what the most appropriate therapy option would be. And of the multiple answers given, the option that the authors are going for is to treat the thyroid hormone insufficiency and concomitant comorbidities, in particular adrenal insufficiency. So the correct answer to this board review option is to give levothyroxine at the high dose of 300 micrograms IV and stress dose steroids. Now, the reason for that is that in myxedema coma, we are looking for the comorbidities that led the patient to be so severely ill. Often adrenal insufficiency is a concern. So again, the replacement of thyroid hormone would be concomitant with stress dose steroids. In the United States, this is often hydrocortisone 100 Q8 or 50 Q6. We also need to look for other precipitating causes, which can include a stroke, a heart attack, or trauma. So all of that being the background, we of course still need to replace thyroid hormone therapy. And in this case, IV is thought to be appropriate because of the extreme illness, critical state of the patient, and the emergency. So a loading dose of levothyroxine, as you can see now, much higher than weight-based. Approximately 300 micrograms is recommended once, with maintenance dose of 50 to 100 milligrams daily, 100 micrograms daily after that. Now, the addition of T3 hormone, the active hormone form, is controversial, but in true myxedema coma, it's often accepted to be necessary, but it must be done cautiously, generally not used alone. Still, we start with the IV levothyroxine, but on top, we can add the T3, but very cautiously at low doses of 2.5 to 10 micrograms. And the reason for that is that it is a short-acting hormone. It must be given every 8 or 12 hours. And the short duration means that we can occasionally have fluctuations in levels and potential arrhythmia, which is why T3 is used only in this extreme situation and with caution. And our final, in the last few minutes, our final case is a mix-up question that gives a scenario of a 27-year-old lady who is known to have hypothyroidism, known Hashimoto's thyroiditis that was subsequently turned to the hypothyroid form, and she was treated with levothyroxine therapy at a weight-based dose of 125 micrograms a day. She's now found to be pregnant. Her labs show a free T4 that is appropriate, but a TSH that's starting to borderline elevate at 4.2. The question is, what's the appropriate management of her levothyroxine? And the answer per the societies, American Thyroid and others, is to immediately increase the dose by 30%. And that is because early in pregnancy, thyroid hormone requirements do go up, and it's essential to aim for a TSH value of around 2.5 or less. Again, trying to aim for the normal range, but again, with the upper limit really considered to be 2.5 in pregnancy. And the reason for this is that we want to have not only a healthy pregnancy, but a healthy baby with good neurologic development. And so that's why I thought it was worth mentioning that the known hypothyroid patient who becomes pregnant should immediately have the levothyroxine increased by approximately 30% for the sake of the mom and especially the baby. And in our brief time, those were the main topics that I was able to cover. I hope this was helpful. I want to thank my resources that I've listed here, and there are also several excellent review articles that I hope maybe have helped you, and so those are listed on the slide as well. I thank you for this opportunity very much, and I hope this has been helpful, and thank you.
Thank you, Dr. Lian, for the elaborative talk on thyroid dysfunction. This concludes our SIMCON 2021, and thanks everyone for participating this event and make it successful. Until we meet in SIMCON 2022, stay safe and have a pleasant evening. Thank you.